Welcome back to another episode. This time we're going to go over the age-old question amongst test writers and students alike, is do you read the answer first or do you read the question first? And this answer can vary, and not everybody agrees on the right way to do it. So this is something that you will need to decide for yourself and may even vary based on the type of question that you get. Our review of the week this week, we are going to start our cardiology review series, and essentially all the way until the second to last week before capstone is going to be cardiology. So from here on out, every review of the week will be cardiac. We're going to basically start back at the beginning this week with A and B, and then we'll go through and recover all of our rhythms and electrophysiology and things like that. Our quiz review will be from last module, quiz 2. And then drugs of the week this week are psych, because we are still in the medical chapter. So we're going to cover olanzapine, Haldol, Geodon, droperidol, and meperidine, which isn't really a psych medicine, but honestly it didn't fit anywhere else, so it made as much sense to go here as anywhere. So let's try a couple of these and see which one you like better, and then you'll know, or we can at least talk about when to use one versus the other. So just read the question. Don't read the answers. In fact, I'm not going to even give you the answers. You need to try to figure out what the answer is. Try to guess what the answer is going to be before you see the end of it. Now, what you can do is come up with a couple potential, maybe this is an assessment at least, maybe this is a treatment that they want, and go from there. So this is an easy one. This is just a straight terminology, A and P. You should be able to get this one right without even seeing the multiple choice answers. So if they give you a basic definition, you won't need the multiple choice. Now, it does kind of help to see it, to maybe confirm what you thought it was, but you should be able to answer this one, obviously being trachea. Now, it gets harder if the question says a spinal injury can lead to. This might not say this. It might give you a scenario where the patient has a spinal injury, and then they ask you, what might you be most concerned with, or something along those lines. So this can be said a lot of different ways, but ultimately it boils down to, what do you expect a consequence to be of a spinal injury? Now, this could be paralysis. This could be neurogenic shock. This could be, maybe it's asking you, can lead to trauma surgery or need for transport to a trauma center. This could be an operational type question. So there's a couple different ways that this can actually go. And then you will get impossible ones, which say which of the following is the most important during an assessment. Anything that says which of the following or which of these is true or something like that, you're not going to be able to guess. So you're just going to have to move on. Read the question, move on, and read the answers. Now, unless one of the answers is maintaining an airway, scene safety, something along those lines, in which point it really doesn't matter. You know that it's always going to be the right answer. All right, now let's go the other way. Let's talk about reading the answers first. So we're not going to read the question. In fact, I'm not going to give it to you. You want to try to guess what the question is. You also, while you're looking at this, want to try to identify 3 to 1s and 2 to 2s. Remember, we talked about those before. So here's 4. An elevated heart rate, dropping blood pressure, rapid shallow breathing, narrowing pulse pressure. So you can identify 3 of these are cardiac signs. Yes, these are all signs. And 3 of them are cardiac. Remember, signs you see, symptoms they tell you. So 3 of them are cardiovascular, 1 of them is respiratory, but it is very closely related. And it could be either rapid or shallow, or rapid and shallow. Dropping blood pressure, narrowing pulse pressure, elevating heart rate. You do have blood pressure for 2 of them. We don't really see a 2 to 2 here. But what could this be? What could this question be? This could be, what is the first sign of shock? This could be, which of the following is a sign of a certain pathology? So rapid shallow breathing kind of sticks out here. Dropping blood pressure and narrowing pulse pressures typically go together. You typically get a narrowing of pulse pressure when you get a lowering of blood pressure. So that actually might be a 2 to 2, I guess. And then elevated heart rate and rapid shallow breathing kind of go together because they are both catecholamine responses. So they could both be compensatory mechanisms. There's a couple different ways that this could go. Now let's go to another one and then we'll come back and look at some answers there. So here's two. Now, normally, I say normally, National Registry tries to reduce the ambiguity as much as possible, which means there will typically not be two things in each answer. And I've really tried, especially from this point forward, now that we're kind of out of the basics of test taking, I've really tried to model that as well in writing these quizzes and exams. Definitely the exams. But you have two things in each answer. And remember, only one has to be wrong for it to be wrong. So you have decreasing the heart rate and vasoconstricting major veins, increasing the heart rate and decreasing systemic vascular resistance, decreasing the heart rate and promoting peripheral vasoconstriction, increasing the heart rate and closing precapillary arterioles. Obviously, this has something to do with shock and compensation, or something along those lines. So if you decrease the heart rate and vasoconstrict major veins, that is going to drop your cardiac output but increase your blood pressure. So those might offset each other. Increase your heart rate and decrease systemic vascular resistance. Again, those might offset each other. Although one might be compensating for the other in both of those, actually. Decrease the heart rate and promote peripheral vasoconstriction. Again, that's working the opposite direction. And in fact, these two are very, very similar to each other. This is major veins and this is peripheral veins. And then increase heart rate and close. So increase heart rate and close precapillary arterioles, which also increases. So this one will actually increase your blood pressure both ways. This one will pretty much balance it equal. So D kind of sticks out. And then there's also a 2-to-2 with the heart rates as well. So let's look. What do we got here? This one, we're looking at signs of cardiogenic shock. So let's go to this again. Elevated heart rate, dropping blood pressure, rapid shallow breathing, narrowing pulse pressure. If we look at Beck's triad, bradycardia, JVD, and narrowing pulse pressures or muffled heart tones, you're probably going to want to say D is the correct answer. Now, the blood pressure will drop, but again, that narrowing pulse pressure is the more specific answer. And then, whoops, went too far. And then this one, I look around my mic, sorry. This is compensating for blood loss, which again would be D. And honestly, you could have probably figured out that this was D just because these three are all contradictory with each other. All right, it's time to get into our review of the week. We're starting off with cardiology. We're going to do cardiology from here until the end of the program. And we want to start with tracing a path of blood from the heart, from right atrium to right atrium always. And the reason I say always is not because that's the way to do it. That's just because that's the way I was taught. And if you always do it the same way, then you will never get confused where you started. So if you always start somewhere, I like the right atrium, not just because it was what I was taught, but because that's also where the SA node is. So that also starts you in your conduction pathway as well. So from right atrium, you go down through the tricuspid valve. Remember, you got to try before you buy. So you go through the tricuspid valve into the right ventricle. This is your low pressure pump. It's going to push through your pulmonic valve. It will push through your pulmonic valve because it's going to the pulmonary artery. Pulma meaning lungs. Pulmonary artery is unique because this is the only artery in the body where your blood is mostly deoxygenated. Artery is away, has nothing to do with oxygenation. Artery goes away from the heart. It's also the muscular one versus veins, which are not muscular. So that goes to the lungs where it picks up its oxygen, not shown here, and then comes back on a ride on the pulmonary vein, dumps it into the left atrium, goes through the bicuspid or the mighty mitral valve, and we called it mighty mitral because it's the strongest valve in the heart because it has to maintain that high pressure system. Goes into the left ventricle, which again is the workhorse of the heart, the largest area of the heart. And it's this picture's kind of misleading because it doesn't show you the 3D, but a heart is basically a left ventricle with three tiny little chambers with it, right? These three chambers are all fairly small and the left ventricle is massive. So the heart is basically a left ventricle. That's why when you do a 12 lead, you're only really looking at the left ventricle itself. But it's hard to draw that and still see the detail that you need. So usually they just draw them comparable. So the left ventricle pushes through the aortic valve. It's called the aortic valve because it goes into the aorta. This breaks off, goes up into the neck, and then it goes down into the descending aorta, breaks off, goes into the rest of the body systemically, does its gas exchange, carries its magic back through the inferior vena cava and the superior vena cava. Once it comes back through these, it dumps it back in the right atrium, and you are home. There is one other thing I want to talk about here. You might hear the term atrioventricular valves, or AV valves. That is your tricuspid and your bicuspid, and they call them atrioventricular valves because they split the atria and the ventricle. It is important here because this is where the AV junction typically rests, is somewhere right around here, and that holds that charge so that all of the blood can flow through those valves. The other one you might get asked is, what is a semilunar valve? That is the pulmonic and aortic valves, and they are called semilunar valves because, as you can see here, they look like little, really not semi, but they look like little crescent moons. So these are your aortic valve and your pulmonary, or pulmonic or pulmonary valve. I've always heard it called pulmonic. This picture has pulmonary valve. I got it from Wikipedia because it's not in public, or it's in public domain. So pulmonary, pulmonic valve, whichever one. And then you basically continue until you die, literally. Now, there is one more that's not on here, but I do have it here, actually. And that is the coming back to the right atrium. There's actually a third one. So there's the superior vena cava and the inferior vena cava, and that's what we talk about all the time. But there's actually a third method that blood gets back into the right atrium, and that is via what's called the coronary sinus. And I believe that one is here. It is not, because this is only arteries. The coronary sinus is a vein, which actually kind of is hidden behind this picture, but you can't see it here. But it'll make sense once we go through this. So if we go through the coronary circulation, then once it leaves the aorta, then blood goes through the RCA, or the right coronary artery. This provides blood to the right atrium and the right ventricle. And then the left coronary artery breaks down into two. So this is sometimes called the left main coronary artery, the LMCA, or the LMC, or the left primary coronary artery, whatever the cardiologist learned in school. And this breaks off into the circumflex and the LAD, or the left anterior descending. Circumflex skirts its way around the side of the left ventricle. Again, remember, the heart is basically a giant left ventricle with 3 little chambers in it. So this circumflex has to cover around the side, the lateral portion. While the LAD is commonly called the widowmaker, because this is the one that if it gets blocked, it's very, very hard to come back from. Whenever somebody says the big one or a widowmaker, they call it a widowmaker because it killed so many people, so many men specifically in their 50s and 60s throughout the last century. And then you can see it breaks down into more and more, which we don't really need to get into. This is from a cardiology page. So really all you need to know for paramedic is the right coronary artery, the LAD, and the circumflex. And the right main. I mean, I say the right main, but it's just a teeny tiny little thing up there. It breaks pretty quick. So those are the 3 that really you need to know. Now, these, once they dump their blood off, they all dump back into a vein called the coronary sinus, and then that vein dumps back into the right ventricle, where it meets up with the rest of it. So you can see cardiac circulation, the heart, remember, does not get its blood, or does not get its nutrients from the blood inside it. It gets its nutrients from the coronary arteries. It's also important here that the heart eats during diastole. The rest of the body eats during systole, which again makes sense because the heart has to eat when it's on a break, right? It can't eat when it's working, whereas the rest of the body can't eat unless the heart's working. So while the rest of the body gets its nutrients during systole, the heart gets its nutrients during diastole. And how that works is during systole, the heart contracts, it forces out this blood, and then when the heart relaxes, whatever blood gets pushed up here is going to fall back down. Now, it's going to fall back down, and it's going to run into what? Hopefully, you just said the aortic valve. Once this blood runs into the aortic valve, it's kind of like if you've ever, seen, I can't think of something, but if you've ever seen like water flowing and then it backflows a little bit and hits it, it kind of spills forward again. It's basically what it's doing. Blood rushes out. Heart relaxes, it falls back a little, it hits the valve, and then it dumps forward. And where it dumps is into these coronary arteries. Notice they're not that big. It doesn't take a whole lot for the heart to get its nutrients, which is why one tiny little clot can create a major problem. So I know I went out of order there. Let's go back up to this top one. Where would a clot land if it was formed in the great saphenous vein? This is one of those vessels that I told you needed to remember. I said there was only a handful of vessels you needed to remember. This is one. Why is this one unique? Because it's the longest vein, and it runs the length of your leg. So now, knowing that this is a deep vein in your leg, where would a clot land if it formed in the great saphenous vein and then became a thrombus? Hopefully you've put two and two together now and heard, oh, deep vein thrombosis, DVT. That is exactly what that is. And where do those DVTs usually land? Well, if you've run on these patients before, you will know that they typically lodge in the lungs. But if you haven't run on them before, we can still work it out. So if we're in the we're in the legs, we are going to take a ride up the great saphenous vein, which is going to dump into the inferior vena cava. It's going to dump in the inferior vena cava, go right into the right atrium, right into the right ventricle. I'm a clot, remember. And now I'm going to shoot out the right ventricle into the pulmonary artery, and really the first small vessel that I hit is in the alveoli. And big surprise, that's where pulmonary embolism are. So the clot lands in the first small artery after where it forms, which is why so many DVTs, deep vein thromboses, or clots in the legs tend to land in the lungs. And if they don't, then that's clearly the most dangerous area where they could land, is in the lungs. Now, what if you formed a clot in the left atrium? Let's say you have atrial fibrillation. Your atria are just quivering, they're not actually pumping, and because they're just quivering, then that's allowing blood to clot. So now I've got a clot in my left atrium. Go back one slide. And this left atrium pushes the clot through the left ventricle, pushes it through the aorta, straight up here, and where is the first small vessel that I hit? It is either the carotid arteries, if it's a really big clot, or if it's a small clot, it's going to land in the brain, which is why AFib patients are at such a high risk of stroke. Now you say, well, what about the heart? How do I get an MI in the heart? Well, if you have a weakened heart, and maybe it's not able to push that clot all the way up in one pump, right? It's a weaker heart. It only pushes the clot up a little ways, and maybe the clot just goes and falls back here into one of these coronary arteries. That's when you get an MI. So AFib patients, typically the heart is still pumping strong because it's just the atria are quivering. The ventricles work fine. So typically with AFib, you see the heart strength works well enough to get the blood up to the brain. With MIs, you usually see a weaker heart, typically not necessarily, I don't want to say typically, not necessarily associated with AFib. So it's just something weak where a clot forms and then gets pushed and dumped into these coronary arteries.